realized that I have some anecdotes of my own. I have a foot in a lot of worlds, and one of those is I have all these pets left over from when my daughter was little, and vet techs, when I've been making some emergency room visits, have been telling me that they've been seeing a lot of accidental ingestions by pets. Also, people are using medical marijuana for their dogs, and a vet tech that I know sort of socially said that it's not necessarily always having the intended consequences. So I thought that that was really interesting. Let's see, in my NICU, recently I had a taxi driver dad, who was really a kind of a neat guy, and his wife was telling me that he had been engaged by two 21-year-olds from New York to take them to Denver to try out all the pot shops. So marijuana tourism. I am not talking about pediatric medical marijuana use, but I wanted to mention, in response to one of Stein's anecdotes or discussions about pediatric patients, as we all know, there's a very prescribed list of things that people can be given a medical marijuana card for. For pediatric patients, I think both parents have to agree and two physicians. Actually, Ted, you probably, is that correct? Yeah. So it's not part of my talk, but I thought that was an important piece of information. And then Dr. Wright was talking about various ways of using marijuana. I had a baby recently whose toxicology screen was positive for THC, and this was confirmed. And the mother said, boy, I just used topical oil a couple of times for muscle pain or something like that. We're seeing our babies become positive for THC in a number of ways. So I have no financial relationships to declare. We're going to talk about epidemiology of cannabis use, what we know currently about in utero exposure to babies, and what we know currently also about marijuana use and lactational exposures. So those were my objectives, but some of the things that people are usually interested in talking about also are our job as physicians and our relationship with child welfare, counseling pregnant marijuana using women, and then recommendations around breastfeeding. So if you have questions about those things, maybe I'll pause between finishing up talking about lactational exposures and then see if people have different questions than those things. Incidence of marijuana use in pregnancy. Two of our previous speakers have talked about the National Survey on Drug Use and Health, and that is probably the broadest base of information about epidemiology in the United States. An author, Coe, looked at 5 years of this national survey data and arrived at a number of 10.9% of pregnant women who had used marijuana in the prior year. And she thought that this was probably pretty close to the number of women who had used during pregnancy period. A couple of years, and 3.9% of the women surveyed had used marijuana in the prior month. A couple of years later, statistics from the NSDUH showed 4.9% of pregnant women reported that they had used marijuana in the prior month. We know from a number of studies that when people are asked about their use of marijuana and other substances, that use is probably underreported. I think we all agree, and this has been alluded to this morning, that probably in Colorado, people are more likely to report actual use than they used to be. But there was a Wisconsin private obstetrical practice who reported that they randomly screened 200 women on their first visit for obstetrical care, and that 7% of those had a urine test that was positive for THC. it was 13 or 14% who actually tested positive for any illicit substance. But of those patients, only 4.5% actually reported any drug use. So to illustrate that illicit substance use and THC use is underreported. In Colorado, we know that the use is higher across the board, especially in young people, than it is in the United States. I do not have my finger on the actual percent of pregnant users in Colorado. I think that we'll get that from the NSDUH and also from a survey called the PRAMS, or Pregnancy Reporting, it's another survey soon. And a couple other statistics. In my NICU, we put in our electronic medical record a diagnosis of THC exposure when we, number one, remember, because it's not ever the primary admitting diagnosis, but when there is a maternal report of THC use, a positive maternal drug screen for THC, or a newborn screen that's positive for THC. We kind of just ran a quick report and found that 9% of 625 babies that we had admitted in the last year were positive. And then there's a WIC survey, just this tri-county area, a little, I think, north and east of Denver, where 3.4% of women, so these are either pregnant women or have children under 5, reported that at some time during a pregnancy they had used marijuana. I have a guess about what our incidence of marijuana use in pregnancy is in Colorado. Based on the 10.9% that Co came up with, the 3.9% who a few years ago reported use in the last month, a subsequent number that is greater, the fact that use is underreported, and the fact that marijuana use is higher in Colorado. And here's my number. I think it's higher than that. What do you guys think? I don't know. Does anybody know what we think it? Yes?
Oh, actually, PRAMS data is available.
That PRAMS data is available on that? Okay. You tell me later. Okay, good. These are some things we know about marijuana use and pregnancy. Use of marijuana is lower in pregnant women than in non-pregnant women, with the exception of very young pregnant women, so the 12 to 17 or 19-year-old, where use is much higher than in their non-pregnant age-matched peers. Use of marijuana in general decreases over the course of pregnancy. Women report using marijuana not just recreationally, but to treat psychological and psychiatric symptoms and distress. There is a high rate of concurrent substance use, and pregnant women in a different WIC survey reported that most of the time their provider did not talk about, ask about, make recommendations about marijuana use in pregnancy, and even less of the time did they talk about marijuana use and breastfeeding. Keep those points in mind for later on. Almost every hospital that delivers babies has some sort of guideline around drug screening. Those tend to be evidence-based guidelines. We have an evidence-based guideline that includes both some psychosocial things like a teen pregnancy and certain medical indications that prompt a screen. I try to apply that across the board. So if you meet one of those criteria, I don't look at you and say, gee, you might or might not use marijuana or meth or whatever, and just apply that in a standard way. We use urine and umbilical cord. This slide right here is from the U.S. Drug Testing Lab, where we send our umbilical cords, and they're all it's kind of a neat site to go to. Do you know that site? It's pretty. This little schematic of an umbilical cord helps me illustrate 2 points. One is it illustrates that THC does indeed cross the placenta into the fetal bloodstream and rests in the fetal tissues. Umbilical cord, of course, is a fetal tissue. And number 2, that there is a high rate of concurrent drug use. Each of these little dots represents 1% of the umbilical cords that tested positive for THC in a 5-month period in 2015. The gray dots represent times that THC was the only substance tested for that was positive. These are the substances: THC, opiates, buprenorphine, OxyContin, methadone, benzodiazepines, amphetamines, cocaine, barbiturates, meperidone, tramadol, PCP, and I can't remember what PPX is, but alcohol and tobacco are not screened for on this. But of the cords that screen positive for THC, you have like about 17% where there are also opioids. There's some methamphetamine, or I'm sorry, some a little methadone in there, some buprenorphine. So to reinforce that there's a lot of concomitant drug use. We talked about the endocannabinoid system, and let me reiterate that there are endocannabinoid receptors in numerous tissues. For the purposes of this talk, they are present in reproductive tissues and in most parts of the brain from very early in gestation. The endocannabinoid system plays an essential role in embryonic and fetal structural and functional brain development. For example, it directs the differentiation between neural progenitor cells into neurons and axons. It has to do with that, with neuronal migration, and is critical for normal synaptogenesis. We had the conversation a little while ago about, what do you tell folks who say, well, I have a whole endocannabinoid system, how about I just add a few more cannabinoids? And I would say the fetus and the newborn in the well state are the most perfectly balanced system you will ever see. And if you throw other cannabinoids in there, it's not in balance anymore, right? So supraphysiologic stimulation of the endocannabinoid system with THC may disrupt developing neurotransmitter systems. I'm going to just hit, my co-speakers and Dr. Fenn kept sending me things, and it kind of expanded upon my original thoughts, but let me just say that alterations of development of the brain may become evident in adulthood or beyond in ways that we do not see in the fetus, the newborn, and the child. And there are a couple theories to explain this. One is the double hit hypothesis, where an alteration of the fetal and postnatal neurodevelopmental trajectory by a sub-threshold hit, one that doesn't become evident, makes the brain susceptible to other prenatal exposures or to postnatal exposures or stressors. For example, THC and subtle alterations, and we're going to talk about some animal data to show some of those subtle alterations, may make the brain more susceptible to another prenatal toxic exposure, another illicit drug, or to maternal malnutrition, or to stress that causes abnormalities in her cortisol levels, or to postnatal stressors like abuse and neglect, secondhand tobacco smoke, or even susceptible to later toxic hits like marijuana use by the affected fetus when they reach adolescence. And then there's also the theory of epigenetics, where a link between the genetic code in the germ cell, the sperm or the egg, and environmental factors may permanently alter the genome. And this theory has been around for a long time, and then it sounds like there's increasing human investigation into this hypothesis. How am I doing on time?
You're fine.
Am I okay? So some preclinical findings. Preclinical means not humans, except I do have some human brain findings here. Animal brain findings. Long story short, when little rat fetuses are exposed to cannabinoids during the pregnancy, there are alterations of dopamine receptors and metabolites. There's a gender difference in the response to that. Alterations in serotonin levels, downregulation of glutamate neurotransmission, and then getting back to the epigenetic theory, there are alterations in the dorsal striatum, part of the brain involved in emotion, addiction, etc. in, picture this, the adult offspring whose parents, this is rats, whose parents were exposed to THC before pregnancy. And the THC had left the the rat system before pregnancy. In human brain findings, there's a study of terminated fetuses at 18 to 22 weeks. The researchers did toxicologies, they asked the moms, and they also did toxicology on the fetuses, and those fetuses that had been exposed to THC compared to non-exposed had decreased dopamine expression in the amygdala that correlated with the amount of maternal intake. There was another gender difference in this expression. And they also looked at concomitant drug exposures and found that this was specifically marijuana or THC, actually marijuana really use in the mom related. And they also found alterations in the opioid system in these fetuses. So rather than remembering each one of those things, I want you to take away from this that each of these findings has potential significance for human adolescent or adult addiction or mental health disorders. All right, animal behavior. These are little rats, and these, I think most of the animal studies are in rats, but these little rats were allowed to reach young adulthood and were looked at for behavior. This is a meta-analysis, or I'm sorry, a review, the Schneider paper. But things that have been found are alterations in motor behavior, abnormal stress responses, abnormal social interaction, learning deficits, and enhanced sensitivity towards the rewarding effects of morphine. All right, what about humans? I'm going to tell you what we find in humans is more difficult to interpret. It's not as definitive. And I will tell you that problems with research in this area can be summed up that there are not prospective randomized control studies of prenatal marijuana use or prenatal marijuana exposure. I have used several meta-analyses and review papers. There are about 4 or 5 really excellent ones in just the last 3 years. And also the Colorado Department of Public Health and Environment has done a wonderful job of doing a literature review. As you probably know, they were tasked with the legalization of, I think it was with the medical marijuana, no, it was with the recreational marijuana, with developing a marijuana retail committee that looks at health and social effects. This is the short bibliography from the most recent review article that was just published this summer. This is about, 25 papers or so that were culled from about 2,000 human papers from the last few decades. This just says that there are a lot of methodologic problems with a lot of these studies. Especially the earlier studies did not objectively define marijuana use. They did the verbal report from the mother. Quantity of use is really critical, and that was not always investigated. Some adjusted well for use of other drugs, including tobacco, and some did not. There are 3 long-running studies that are included in everybody's review papers and meta-analyses. And to be conversant about prenatal exposure to marijuana, you should know about these studies. The Ottawa Prenatal Prospective Study began in 1978. This study sampled low-risk, white, predominantly middle-class families. There have been ongoing publications from this study. The Maternal Health Practices and Child Development Study in Pittsburgh began a few years later. The population that they looked at was kind of the opposite, low socioeconomic status, just over 50% African American. But this study control a little bit better for other drugs, including tobacco, a little bit better than the Ottawa study did. And then the Generation R study began just about 15 years ago, is a much larger study of nearly 10,000 mothers in the Netherlands. This study is looking at all kinds of social and behavioral and pregnancy practices, with cannabis use being a part of that. And these are the numbers of pregnancies that they had to look at. And they thought, I'll talk about these studies a little bit more. When people review the whole body of literature, I'm going to go through some of the things that that have been found. Birth defects. We think of teratogens like alcohol as causing sort of a pretty defined group of commonly recurring findings. So a syndrome, so fetal alcohol syndrome is microcephaly and some cleft lip and palate and ventricles, or congenital heart disease, and long-term cognitive problems. There is not a specific marijuana exposure syndrome. There's no convincing evidence of any overt structural defects. People have looked at neural tube defects, gastroschisis. There were some early reports of increased rates of ventricular septal defect. That has not actually been subsequently corroborated. But as we've already talked about, the central nervous system is vulnerable, we think. There may be an increased rate of stillbirth. There certainly is an increased rate of stillbirth when tobacco and any illicit drug, and marijuana was included in this, are looked at. There was a pretty large study looking at 660 stillbirths compared to 1,932 liveborns, and toxicology screening was done on all of those stillborn and liveborn babies, and these were the findings. Growth. I have lumped fetal growth, low birth weight, small for gestational age, kind of all together, but it is really plausible that growth would be affected by marijuana use, by excess cannabinoids. Stimulation of the cannabinoid receptors, which are present in all layers of the placenta, may impair fetal growth by inhibiting cytotrophoblastic proliferation. In that study of terminated fetuses at 18 to 22 weeks, those fetuses were smaller by about 1/2 ounce than non-exposed fetuses. I did a quick calculation on what I thought a fetus that gestation should weigh, and I'm thinking that's about a 5 to 10% decrease. The Generation R study in the Netherlands has done some kind of interesting things. One thing that they did was to follow the pregnancies by ultrasound monthly, and they looked at fetal growth. They also looked at birth weight, and they also looked at uterine blood flow. And they found actually a small decrease in fetal growth. Their birth weights were a little bit smaller. It wasn't necessarily enough to be a huge clinical significance, but it was a statistically significant decrease in birth weight. And they also found high uterine artery pulsatility and resistance index, meaning basically alterations in blood flow to the uterus. Tobacco is known to have actually sometimes a very large effect on fetal growth, and birth weight can definitely be a confounder. Besides the Generation R study, there are a number of conflicting reports. One study even showed babies being a little bit larger when they were marijuana exposed. So I would say, although the findings appear compelling, we don't really know. Again, there are a lot of barriers to really knowing for sure where we're going with human studies. Preterm birth, plausible, there could be an effect. Data is inconclusive. Newborn behavior, the Ottawa study reported increased startles, tremors, and hand-to-mouth behaviors. These findings were not duplicated in the Pittsburgh study or the Generation R study, but other people have reported that. I see a lot of jittery babies. I cannot tell which ones are jittery because of marijuana exposure or hypoglycemia, or sometimes we just don't know. So I can't corroborate that finding specifically. And then long-term outcomes. Here's a cheat sheet on the Pittsburgh and Ottawa studies. But basically, we look at behavior. School behavior reports in the Pittsburgh study was that there was increased impulsivity and hyperactivity at age 10. There were also some reports that parental reports of increased hyperactivity at age 6. There's limited evidence about delinquency. Both the Ottawa and the Pittsburgh studies reported increased use of marijuana and cigarettes at age 14 in their exposed offspring. As far as mental health goes, there were increased depressive symptoms described in 10-year-olds in the Pittsburgh study. And psychosis has been thought to be equivocal in terms of effect, but there is good theoretical reason based on the preclinical studies that we talked about. That's why I went through those rat studies. And then the Pittsburgh study just recently published data on their 22-year-olds, and although they did not have an increase in psychosis, and if you're a psychiatrist in the room, pardon me, but my understanding is psychotic symptoms does not necessarily mean psychosis, but it can be a prequel to psychosis. So there were increased psychotic symptoms in these 22-year-olds who had been exposed. The combination of early marijuana use, for which they are at risk, right, increased that association. Dr. Wright, when we're done, I want you to show me how to put hyperlinks to your references. All right, IQ, cognitive function, and school achievement. In the low socioeconomic offspring in the Pittsburgh study, and these are not the same studies, they're not comparing to each other, but it is possible that differences between the studies have to do with their middle class populations versus their low socioeconomic status populations, right? In the Pittsburgh study, IQ was lower in early childhood. There was a greater effect, interestingly, with later gestation exposure. And there was a little bit of a mitigating effect in the white offspring of preschool. So preschool and being white was more, you were less likely to have a lower IQ if you're an exposed offspring. Cognitive function has been something that the Ottawa researchers have really focused on. They found problems with visual memory, analysis and integration, and interfacing, or that interfered with school achievement scores. They did some interesting functional MRI studies in the early, like 18 to 20-year-olds, where the kids underwent a functional MRI, had to do a very simple task involving visual memory, and though the unexposed and exposed kids did both pass the test or did about the same on those tests, they had very different neural activity during the functional MRI. And then last, the Pittsburgh researchers talk about their adolescence as the kids age, the frontal lobe becomes more active, and you can start to see a difference between people with a well-functioning frontal lobe and one without. And they talk about big differences in executive function in the exposed offspring versus the not. And then school achievement at ages 10 and 14, the Pittsburgh offspring had lower global and reading scores that were not identified in the Ottawa offspring. The summary of this slide is that the findings in general are inconsistent, but there is moderate evidence to support that there is an effect of prenatal marijuana exposure on these things. This is executive function. I took my summary about prenatal exposure to marijuana from one of the reviews that was published a couple of years ago because it said things so beautifully. Evidence about the effects of marijuana use during pregnancy are inconclusive. Data from preclinical studies is suggestive of negative outcomes of disruptive effects on the endocannabinoid system. Longitudinal studies indicate subtle effects on attention, executive functions, and behavior. Today's marijuana, as has been mentioned earlier today, is 6 to 7 times more potent and more likely to be consumed in greater amounts by younger users. Thus, continued surveillance is warranted and may reveal more significant short-term and long-term harms. This slide, I'll let you read it for yourself if you like, but basically the point is, as marijuana is normalized, certain groups, including pregnant women, think of it as safe and are using it more. At the same time, pregnant women are being criminalized or charged with child abuse, and it is imperative that educational efforts are imperative to ensure women are not misled into believing that marijuana use in pregnancy is without possible damage to the developing fetus. How much time do I have?
If I can.
Oh dear, okay. I'm going to skip then pretty quickly. 15, okay, THC is transferred into the breast milk and absorbed by the infant. Here's the data on that. In 1982, there was a letter to the editor by this researcher, Perez Reyes, who said that 2 women had come to him or her saying they were breastfeeding their babies, how much THC was in their breast milk. One of these women was a very chronic, heavy user. The concentration of THC in her milk compared to her plasma was 8.4 to 1. We toss around a lot that THC concentrations in milk can be 8 times what's in the mom's plasma. This is the data to support that. I think that we have every reason to believe that that is true. We know THC is stored in fat, especially in chronic users. There's a lot of fat in breast milk. And there is animal data to support this. And then children drinking buffalo milk in Pakistan. The buffalo were grazing on natural vegetation, among which was naturally growing marijuana plants, had metabolites of THC in their urine. Children who drink mom's milk or buffalo milk are ingesting the THC, absorbing it, and metabolizing it. There's very little data about the effect of lactational exposures in infant development. This one just kind of accidental study showed maybe a little bit of effect on motor development at a year. There's a lot of information to be gained in the next few years, probably from our population. THC passes to nursing infants. It's lipophilic and concentrates in breast milk. Biologic reasons to think there might be neurodevelopmental sequelae. Concentrations of THC are much higher. Contaminants, did Dr. Wright talk about contaminants? And then there's not much evidence about neurodevelopmental effect. More study is needed. Okay, I can talk about these things. Do I have like 5 minutes to answer questions now? 5 minutes. Should I talk about these things, or do you have questions? Talk about these things unless I see hand going. Okay. DHS and medical care providers' requirements and responsibilities. Colorado House Bill 12-1100 says women may seek prenatal care for the improved outcome for themselves or their babies. And if drug use is identified during that time, that information is not admissible for criminal proceedings. My opinion is that that is a very good thing because we want for women to get into pregnancy care and seek help at that time if they're using illicit substances or marijuana or alcohol or tobacco. But after babies are born, if the child tests positive Hospitals, medical providers, social workers are obligated to report that information to DHS. Counseling pregnant women. That's an important piece of information to tell them that if their child screens positive, that information must be reported to DHS. Some high points here are, again, women report that their doctors are not talking to their care providers, are not talking to them about marijuana. That's probably because we don't always know what to say. We need to remember that some women use for self-medication, and we should be treating them with drugs with known safety profiles, or referring them for substance abuse. And we need to recognize that if all we do is tell them don't use marijuana, they may use something that we think might be more dangerous in pregnancy, like alcohol. And then, I think those are the high points. I'm not going to open these, but these are Colorado Department of Health and Public Environment documents that are incredibly useful. This one on pregnancy and breastfeeding is a 2-page, it's like you can print it on both sides. It's beautiful. I think it's really useful. We've talked about how we don't really know how to counsel people. Different populations respond differently to different information. I would make an appeal that we not use the reefer madness approach. There is plenty of accurate evidence to just inform people, that we don't have to be scaring them about things that, that we don't know. We can just tell them the facts. But we know that people respond differently to than we as responsible adults might to facts. Recommendations around breastfeeding. This AAP 2015 statement, breastfeeding mothers should be counseled to reduce or eliminate their use of marijuana to avoid exposing their infants to this substance, etc., is sort of standard now. We went through at Memorial Hospital the question, what if they had a month ago and they could still be using a positive drug screen for marijuana? Should we let them breastfeed? And we know that women who want to breastfeed their babies want to be good moms. We know that breast milk is really good. We know that there are unknown consequences of THC exposure to babies, newborn babies, toddlers, etc. So we don't know exactly what the right answer is, but we arrived at counsel, talk, don't prevent breastfeeding, except in the, here's our kind of little statement here. I can't read it here. If it's a well newborn and the mom has a report of cannabinoid use or a positive screen and is not currently under the influence, there are no other contraindications such as other drugs of abuse, then the nurse and the lactation consultant can provide information, assist with initial breastfeeding, and then the social worker and pediatrician catch up later and find out, about chronicity of use, how much the mom uses, and make recommendations from there. That's my, here.